When we talk about the world of toddlers and preschoolers, the default image is usually this robust, healthy, energetic kid. And thankfully, that's true for most.
It is, yeah.
But for a surprisingly large group, childhood nutrition is, well, it's far from simple.
Hmm.
We are diving today into the crucial complexities around children with special health care needs, or CSHCN, as they're often called.
Right. CSHCN. It's a key term here.
Okay, let's unpack this.
Let's do it.
Our mission today is really to distill the essential knowledge. We're looking at intervention strategies, unique nutritional needs for these young children, ages 1 to 5, who are living with chronic conditions or disabilities.
Yeah, and the numbers are pretty staggering when you look at them.
They really are. The source material highlights this statistic from the Health Resources and Services Administration, HRSA. Nearly one-fifth, like 19.4% of all kids in the U.S. have a special health need.
That's about 14.1 million children. That's a huge number.
Huge. And here's the kicker, the stat that really grabbed me. Up to 90% of children with disabilities, they have some kind of nutrition problem.
90%. That figure just immediately tells you we absolutely cannot treat this group as, typical.
Right.
CSHCN, it's a broad term. It covers any infant or child who is either born with or maybe is at risk for a physical or developmental disability or a chronic medical condition.
And these conditions are all over the map, right? Genetic disorders, birth trauma.
Exactly. Or sometimes just being born extremely prematurely.
Yeah.
It's a very diverse group.
Okay, so the key difference then is that the standard guidelines, like the dietary guidelines for Americans,
Yeah,
they don't quite fit.
they really don't. They're built for a healthy, typical population. For a child with a chronic health challenge, those standards are only ever a starting point. Maybe not even that sometimes. They absolutely require customized assessment, specific interventions, because their basic metabolic needs, their growth patterns, they're just inherently altered, different.
And the sources really stress that the clock is ticking here. The earlier you start interventions, the better the overall developmental outcome.
Definitely. Early intervention is crucial.
But that diversity you mentioned,
Yeah.
it must make identifying the problems and figuring out the intervention pretty complicated.
It does. You see such a range.
Yeah, like the examples in the text, there's Bill, 18 months old, born preterm. He's dealing with seizures and has this severely self-restricted diet, only pureed foods.
Right, a very specific set of challenges.
And then you compare him to Sue, who's 4 and has autism spectrum disorder, ASD. Her issues aren't seizures, they're more behavioral.
Often sensory or behavioral, yeah.
The analysis showed she was drinking way too much liquid, too much sugar, and was low on calcium, vitamin D, iron. Really critical nutrients.
And those two examples, Bill and Sue, they perfectly illustrate why we need these comprehensive, coordinated systems. You can't just have one-off clinic visits.
So what systems are in place?
Well, a big one is the Individuals with Disabilities Education Act's IDEA, specifically Part C.
Okay, IDEA Part C.
Yeah, that's foundational. It funds federally mandated early intervention services.
Yeah.
This is for children up to 36 months old. If they show a developmental delay, could be cognitive, physical, communication, social, adaptive.
So it covers a lot of ground.
It does.
Yeah.
And another really critical concept that comes up is the medical home.
A medical home. That sounds like a place.
Not exactly. It's more of a model of philosophy, really.
Yeah.
It's about coordinated, comprehensive primary care. It's designed to build a partnership.
A partnership between who?
Between the family, the child, the primary clinician, and the whole team. Specialists, therapists.
That sounds amazing, but also really resource intensive. I'm thinking about that example, Isabella, 20 months old, needing 12 medications a day, plus PT, speech, occupational therapy.
Yeah.
How realistic is it to coordinate all that, especially for families who might be struggling with resources already?
It is extremely challenging, no doubt. But the source material is really clear. For these complex cases, that coordination is basically non-negotiable. It has to happen. The medical home idea, it pushes beyond just the clinic walls. It brings in education, specialty care, family support, precisely so that a child like Isabella, who might even be technology dependent, doesn't fall through the cracks in our often fragmented health system.
That coordination makes sense because, like you said, the standard nutritional assumptions just don't work. The DRIs, the dietary reference intakes, they give a baseline, but chronic conditions just throw that baseline way off, especially for energy needs.
Completely. It
Look.
changes the whole picture.
So is it fair to say this population is almost always struggling with either being underweight or overweight?
That's often the case, yes. These chronic conditions lead to altered energy needs. So you do see higher rates of both underweight and overweight issues compared to typically developing children. The variation is just huge.
Can you give some examples?
Sure. Think about conditions that generally require high energy intake. Things like cystic fibrosis, pediatric AIDS, or bronchopulmonary dysplasia, or BPD. These often need significant catch-up growth.
Right, right. BPD from being premature.
Exactly. Then you flip the coin. You have conditions often associated with low energy needs. This puts the child at risk for excess weight gain,
Like what?
like Down syndrome, spina bifida, or Prader-Willi syndrome, often because of lower muscle mass or maybe reduced mobility.
Wow, okay. So if energy needs are swinging wildly like that, measuring growth must be, well, a nightmare. How do clinicians track progress if the standard charts don't fit?
It's definitely tricky. They start with the standard tools, the WHO charts for kids up to 24 months, and then the CDC charts after that.
Okay, the usual suspects.
That's right. But here's the crucial part. They absolutely must also look for and use specific growth charts developed for particular chronic conditions whenever they're available.
Ah, condition-specific charts.
Yes. Those give a much more accurate picture of what normal growth looks like for that specific child with that condition. And of course, for preemies, you have to meticulously factor in corrections for prematurity.
Makes sense.
And another thing we put huge emphasis on in these toddler years is head circumference.
Head circumference. Why is that so important?
It's not just routine data. It's a vital screening tool, especially for neurological conditions. Think about Rett syndrome.
Okay.
It mostly affects girls, and one of its key signs is a reduced rate of head growth, starting right in these toddler years.
Oh, wow.
Or conversely, microcephaly, where the head circumference is way down, like at or below the third percentile, that signals an immediate need for screening for cognitive and neurological issues.
Okay, that's critical information. Let's shift gears a bit from the charts to the actual act of eating. Because feeding difficulties, those are often the first, most obvious signs that something else is going on, right?
Absolutely. They can be huge red flags.
Which brings us to a specific diagnosis mentioned, avoid and restrictive food intake disorder, or ARFID.
Yes, ARFID. It's a serious clinical diagnosis. And the key thing to understand is that it's an eating disorder, but it's not about body image, like anorexia.
Okay, so what defines it then?
It's defined by inadequate calorie intake, usually because of really intense sensory issues, maybe hating certain textures, smells, or maybe environmental factors like severe anxiety around eating,
And the consequence.
poor growth, poor weight gain, nutrient deficiencies. It needs treatment.
And beyond ARFID, you also see challenges just with the basic mechanics, the motor control of eating. You mentioned muscle tone issues.
Yeah, that's fundamental. For children with conditions like cerebral palsy or Down syndrome, they might struggle with hypotonia, which is low muscle tone.
Hypotonia, low tone.
Right, muscles feel sort of floppy, like cooked spaghetti. They can't provide the postural support needed to sit up straight, to chew effectively, to swallow safely.
Or the opposite, hypertonia.
Or hypertonia, which is high muscle tone, spasticity. Either way, if those core muscles needed for sitting, chewing, swallowing are compromised, self-feeding becomes incredibly difficult, sometimes impossible.
And dangerous.
And potentially dangerous. That low tone, hypertonia, really increases the risk of choking or aspirating, inhaling food or liquid into the lungs.
Which can lead to serious lung problems.
Absolutely. And in the most severe cases, where aspiration is a constant serious risk, like the case study Roberto, who kept aspirating liquids, the intervention might have to be a gastrostomy.
A feeding tube.
Yeah, a feeding tube placed directly into the stomach.
Yeah.
It ensures safe nutritional delivery when eating by mouth just isn't safe.
Okay. Shifting again, let's talk about challenges that aren't purely physical motor control, but more behavioral or sensory, like with autism spectrum disorders, ASDs.
Right. ASD presents unique feeding challenges.
If a child's sensory issues mean they'll only eat, say, white foods or crunchy foods, how on earth do you manage their nutrition?
It takes a lot of patience and consistency. For kids with ASD, routine is often paramount. Their sensitivities mean they thrive on predictability.
So consistency first.
Yes. Intervention usually involves making sure they're getting adequate nutrients overall, maybe through a carefully chosen supplement if needed. And then it's this long, patient process of introducing new foods. The textbook mentions you might have to offer a new food again and again, sometimes 15 or 20 times over weeks or even months, just to get them to accept it.
Wow, 15 to 20 times. That requires dedication.
It really does.
Mm.
And while we're talking feeding habits, we absolutely have to mention excessive fluids. It's a common toddler issue, but often amplified in CSHCN.
You mean too much juice?
Exactly. The American Academy of Pediatrics is really clear. Limit juice to 4 to 6 fluid ounces a day for kids ages 1 to 6.
4 to 6 ounces, that's not much.
It's not. And when a child drinks way more than that, especially juice loaded with sorbitol or sucrose, a couple things happen. One, it displaces milk and solid food, leading to poor nutrient intake.
Okay.
And two, it's often the direct cause of what's called toddler diarrhea, loose stools, in an otherwise healthy child. Sometimes just cutting back the juice solves that whole GI problem.
That's a simple fix, at least.
Sometimes it is, yeah.
Let's move on to some specific conditions where nutrition is really front and center in the therapy. We have to start with failure to thrive, FTT.
Right, FTT. Clinically, we define that as a child's weight for age dropping below the 5th percentile on the growth chart, or their weight gain slowing down so much it crosses 2 major percentile lines downwards.
And you said earlier this is tricky in toddlers because their appetite normally decreases a bit anyway.
Exactly. Typical toddlers can become pickier eaters, but in CSHCN, FTT is often a symptom pointing to something deeper, maybe an underlying neurological issue, a chronic digestive problem like celiac disease, or even a breathing problem making eating exhausting.
So once you figure out the underlying cause and address it, what's the nutritional goal?
The goal then becomes catch-up growth,
Catch-up growth.
which means that child actually needs significantly higher energy intake, more calories than a typical child of the same age. They need that extra fuel to accelerate their growth rate and get back up onto a healthier growth curve.
Okay, that makes sense. Speaking of digestive problems, let's focus on celiac disease.
Celiac is a really serious autoimmune condition. What happens is when someone with celiac eats gluten, the protein in wheat, rye, and barley, their immune system attacks and damages the lining of the small intestine.
And how does that show up in toddlers?
Usually classic GI symptoms, vomiting, bloating, really poor growth, often foul-smelling stools because nutrients aren't being absorbed properly.
And the treatment?
The critical, absolutely non-negotiable intervention is a strict, complete restriction of all gluten for life.
Wow, complete restriction. That must be tough.
It is. And because celiac sometimes co-occurs with other chronic conditions like type 1 diabetes or Down syndrome, caregivers for these CSHCN have to become absolute experts at reading food labels, understanding cross-contamination, constant vigilance.
Yeah, that sounds incredibly demanding. Okay, let's pivot to the lungs. You mentioned bronchopulmonary dysplasia, BPD, earlier. This often affects preemies who needed oxygen support. Why is that still a nutritional issue in the toddler years?
Because children with BPD, even as toddlers, often need extra energy just to breathe. They have an increased work of breathing, or WOB.
Work of breathing, WOB.
Right. They're literally burning significantly more calories than their peers just trying to get enough air. It creates this chronic calorie deficit if you're not careful.
So how do you combat that?
The feeding strategy has to focus on small, frequent meals that are packed with calories-concentrated energy sources. This often means using commercial supplements like Pediasure or similar products designed for this.
And getting enough nutrition helps the lungs themselves.
Yes, absolutely. Nutrition is so critical here because new lung tissue actually continues to grow until a child is about 8 years old. So really focused nutritional support can potentially lead to the resolution or at least significant improvement of the BPD over time.
That's hopeful. Okay, finally, we need to touch on food allergies. They affect, what, 2 to 8% of kids?
That's the range, yes. And the big danger, of course, is anaphylaxis.
A life-threatening reaction.
Exactly. Now, the good news is that cow's milk protein allergy often resolves during the toddler years. But confirmed allergies to other major players like peanuts, tree nuts, eggs, soy, wheat, those require strict, lifelong avoidance.
But there's a caution here, too, isn't there? About self-diagnosis.
A huge caution. One study found that something like 35% of parents believed their child had a food allergy and were restricting foods unnecessarily.
35%?
Yeah, and that unnecessary restriction puts the child at real risk for nutrient deficiencies. You absolutely need proper professional diagnosis allergy testing before you start pulling essential foods out of a child's diet.
That's a really important point. Okay, so bringing this all together, what does this mean for caregivers trying to navigate this incredibly complex world?
Well, one strong message is caution around unprescribed dietary supplements.
Right, the herbal remedies, the non-traditional stuff.
Exactly. Parents of CSHCN are understandably often desperate. They want anything that might help, and they might turn to products recommended by, maybe well-meaning, but perhaps not scientifically grounded advocacy groups or online forums.
And that can be risky.
It can be really risky. The source material emphasizes that professional organizations actively caution against using these unverified supplements. There's a specific example for Down syndrome,
What's that?
that basically no specific nutrient or herbal remedy has ever been shown scientifically to improve intellectual functioning in children with Down syndrome, despite claims you might see online.
So the advice is?
Talk to your medical team first. Discuss any supplement, whether it seems natural or not, with a trusted doctor or registered dietitian before giving it to your child.
Absolutely. And thinking systemically, we also have to acknowledge things like the COVID-19 pandemic, right? That must have thrown a wrench in things.
Oh, definitely. It caused major service interruptions,
Yeah.
school lunches stopped, early intervention programs faced challenges, and that just increased the risk of malnutrition, obesity, and that concept of hidden hunger, where kids get calories but not enough nutrients, especially in these already vulnerable groups.
So if you are a caregiver listening and you need help, where do you start? What are the access points?
Often, services can be accessed through established community programs, things like WIC, Women, Infants, and Children, state early intervention programs, or local school district outreach efforts, often called Child Find. They're designed to identify kids who need help.
Okay.
And crucially, the sources also point out the importance of specialized training for the professionals involved. Nutritionists who are really equipped to handle these complex cases often get advanced training through programs like LEND,
Lynn.
Leadership Education in Neurodevelopmental and Related Disabilities. These programs train doctors, nutritionists, therapists, a whole multidisciplinary team, specifically in providing coordinated, family-centered care for CSHCN.
Okay. Great resources to know about. So let's try to recap the absolute essentials for our listeners.
Sounds good.
First, children with special healthcare needs have incredibly variable nutrition requirements. It's all about customization.
Absolutely. No one-size-fits-all approach works.
Second, clinicians have got to look beyond just the standard growth charts. Use those condition-specific ones whenever possible.
Essential for accurate tracking.
Third, keep an eye on atypical growth signals, like those changes in head circumference we talked about. They can be vital clues for conditions like Rett syndrome or microcephaly.
Definitely key diagnostic indicators.
And maybe fourth, just be really wary of unverified supplements and miracle cures. Stick with evidence-based advice from the medical team.
Please do. That's critical.
Supporting CSHCN clearly demands precise knowledge, a lot of patience, and that truly coordinated multidisciplinary care you mentioned.
It really does. It takes a village.
We know early intervention is key, and good nutrition supports everything else. But here's a final thought to leave you with, building on what we've discussed. As modern medicine gets better and better at saving extremely premature infants.
Which is wonderful, of course.
Of course, but could we be, paradoxically, seeing a long-term increase in the prevalence of chronic conditions like BPD or cerebral palsy appearing in the toddler population?
That's a really interesting and complex question. What are the downstream effects?
Exactly. What are the long-term societal adjustments we'll need to make to adequately support the lifelong needs of this potentially growing group? Something to think about.